let's get started. So we're going to talk about fatty liver today. And I want to update you on this new term, which I mentioned, I think, briefly when we were face-to-face recently, called MAFLD, metabolic associated fatty liver disease. NASH, NAFLD is going a little bit out of favor, especially globally, because you don't really want to say non-alcoholic if alcohol is a problem or a contributory factor. Metabolic just covers everything, and then you stage patients talking about whether it's inflammatory, fibrotic, what the alcohol component is. So it's really important that you know about this in-process name change. And disclosures are on my website, of course. A little bit more on terminology here. This word hepatitis, steatohepatitis, really means inflammation. Inflammation is very commonly associated with fibrosis. And enzyme elevation above 30 is a trigger for higher risk for hepatitis, inflammation, and fibrosis. You can have cirrhosis even with low or normal healthy AST and ALT, less than 25 for women, less than 35 for men, but it's much less common. So enzymes do give you a crude assessment about the risk or the presence of fibrosis, but it really triggers you to do a FIB4 or imaging, non-invasive testing, elastography. In every patient with fatty liver, you need to do a full assessment of alcohol use. That includes a CAGE score, audit, preferably. I use Michigan alcohol self-assessment test. And then when it's combined, you tell the patient it's combined. You have fatty liver from metabolic syndrome and alcohol is contributing to that. There really is no safe level of alcohol for people with fatty liver. So I just tell people 0 and see if I can get them close to that amount. You need to think about each patient as this overlapping Venn diagram, but think about other causes of fatty liver besides metabolic syndrome and alcohol, which can include rare conditions such as Wilson disease, or LALD, which I've seen one case of in Las Vegas. It's only 1 in 100,000 people. But you don't want to miss unusual disease states, genetic diseases that lead, or drug-induced diseases that lead to fatty liver, such as valproic acid or tetracycline. This is very important on this slide for 2 reasons. In the lower right-hand corner, you see this word lipotoxicity. And that really is the disease state that's ongoing in these fatty liver patients. It's a fat process, it's an inflammatory process, it's a toxicity process. The other point on here is that cryptogenic liver disease is very rare. A lot of most cryptogenic liver disease has actually been fatty liver over the last 2 decades after we got much better at working up autoimmune liver disease. Here's a nice graph just talking about alcohol and metabolic associated fatty liver disease. This only goes up to 2016, but during the COVID pandemic, these numbers have skyrocketed. It's a huge problem of alcohol and obesity, calorie intake, sedentary weight gain that's all happening over the last 2 years, leading to another pandemic within a pandemic. Moderate alcohol use. Some people claim that it was going to improve fatty liver, and some studies, small studies, came up with some data, but this has been countered by many other research studies that did not show a benefit, and definitely many studies have shown worsening of fatty liver disease. So there is no safety zone, there is no safe limit, so tell your patients not to drink. Disturbing evolutionary development, you can see here. What's really important here is that red cup in the man's hand full of fructose, and we'll get into fructose later in terms of being toxic, including a mitochondrial toxin. When I see fatty liver patients in clinic, I give them this graph. I hand this to everybody, and I have a Spanish version as well. I talk about kidney injury that's separate from hypertension and diabetes. Fatty liver directly affects GFR and may cause kidney damage in and of itself. Heart attacks, strokes, myocardial infarction, congestive heart failure, orthopedic issues, knees, back, hips. The body, the spinal cord, and the skeletal structure is really meant to be fully operational with a BMI of 24 for Caucasians and 22 for Asians and South Asians. Sleep apnea, sleep disorders, cognitive changes, chronic fatigue are all part of the fatty liver metabolic associated fatty liver disease. 13 different cancers appear to be increased in people who have metabolic associated fatty liver. Of course, we have cirrhosis, liver failure, liver transplant, and death. So I really try to motivate people. I give them these bad things associated, but I say by losing weight, you're going to extend your life and your quality of life by 5, 10, 20, 30 years, depending on how ill that patient is and what their trajectory is for their liver disease. This is, called motivational counseling. It's a new form of really you and I participating in the psychiatric or psychological treatment of your patients. Bad news on this graph is the Middle East. That's got the highest percent rate of MAFLD. That's over 31%. This has to do with inactivity, the women being in a restrictive social environment, having to wear total body covering, can't be out alone. Sort of Saudi Arabia is sort of the worst case scenario. Even Iran, which I went to in 2017, women had to wear head coverings, but that was about it, and then be on a separate part of the bus. But otherwise, the women were, interacting with everybody in a normal social environment. But look at the calories per day. Most of us need about 1,800 calories a day, maybe 2,000, 2,400 if we're super active. This massive calorie excess is what's driving obesity and fatty liver. This is looking at normal liver, fatty liver plus hepatitis and fibrosis, inflammation, ballooning, and then cirrhosis. And that red line at the bottom gives you this worldwide prevalence. So you have to really look at this. 25% of the world has fatty liver. 3 to 5% of the world has inflammation and fibrosis. And then this at risk, we'll talk about that a little bit later and what those subgroups are. On this graph, we're going to talk a little bit more about this pro-inflammatory, but more importantly, a pro-thrombotic state. A lot of us feel that progression of cirrhosis is a pro-thrombotic state with microthrombi in the portal venules causing ischemia, recanalization, regeneration. And if you can block that prothrombotic state with things such as Lovenox, you can markedly improve survival and decrease the risk of liver failure. And that's been shown in a very large prospective study, randomized prospective study that was performed in Spain, but hasn't been repeated yet. So until it's confirmed, it's going to be a little hard to start bringing that in as standard of care, as putting all of our cirrhotic or early cirrhotic patients on an anticoagulant. On here is just a little bit more of a build because you've got fatty liver on the right and diabetes, cardiovascular disease on the left. Now you're going to see a little bit more of this graph as we do a build, but insulin resistance is key. Even slightly elevated blood sugar, slightly elevated hemoglobin A1C is a strong trigger or signal of insulin resistance. Cytokines, adipokines, oxidative pathways, apoptosis, autophagy are all going on, causing that liver destruction, inflammation, and fibrosis. Most important thing on this slide is just talking about dysmetabolism of VLDL, high levels of VLDL, high levels of circulating triglyceride, loading that liver with triglycerides, dysfunction of bile acids, the type of bile acids that are present. And we'll get into this in some more detail when we're talking about the biome. Epidemic. This was 2014, almost 8 years old, but you can see the red states that are here. Huge problems in terms of this self-reported obesity among US adults. And this has just expanded. This whole country was green in the 1950s. So big, big change driven by junk food, fructose, low levels of activity, high calorie intake. This NASH or MAFLD prevalence is higher in Hispanics, lowest in Caucasians, mid-range African American. Important on here is every patient needs to be worked up for thyroid. Make sure there's a TSH. You've done a sleep history, and you look for unusual conditions such as pituitary insufficiency in young women or younger women, polycystic ovary syndrome. And we have lean patients, have a normal BMI, but have an increased waist circumference. They have visceral fat. That visceral fat can drive cirrhosis. Back to simple steatosis, NASH, cirrhosis. Simple steatosis does not progress. It occasionally can go from steatosis to NASH, but that number is not known. Once you have NASH, your risk of cirrhosis is 15%. 7% of liver cancer, although we're seeing liver cancer in fibrosis level 3 NASH patients. 10 years, we're talking about a build. What's the timeline? Now, this is a little bit more aggressive to say in 10 years, somebody has a 20% chance of cirrhosis. Well, that may be true, especially if they have F3 or advanced F2. If somebody's got minimal fibrosis, steatosis plus F1 or early F2, progressing to cirrhosis may take 30 to 40 years. GGT is one of my favorite liver enzymes. I hope your whole team is using the correct terminology for AST and ALT. These are not liver function tests. These are liver enzymes. And here you have GGT as a surrogate for cardiovascular disease, stroke, myocardial infarction, and heart failure. GGT is a cornerstone of your liver assessment, but also correlates with progressive cardiac disease. Fibrosis drives outcome in the liver realm, liver-related mortality. And you can see patients with fibrosis level 4 have an extremely poor survival of around 50% at 150 months. So that's about 12 to 13 years. NASH is the fastest growing cause of HCC among liver patients. Patients with alcohol-associated liver disease do get liver cancer, but they often are dying in car accidents, some type of trauma or violence or gunshot wounds. This is really important from a liver-related and overall mortality rate here. Liver-related mortality in just simple fatty liver is very low at 1.7%, and overall mortality is about baseline. But once you get NASH, you have a big jump up in liver-related mortality and a small jump in overall mortality. And then once you have cirrhosis, you've got this increased liver-related mortality, but overall mortality rebalances that, and it's a little bit lower because they're dying of cirrhosis. Fructose, directly proportional to weight trends. Fructose is a poison, it's a conspiracy. There's some great movies and documentaries on this. You and your patients need to have fructose out of your diet. Natural sugars in fruit, acceptable, because you're eating that fructose with fiber, with other types of carbohydrate typically. This is fructose in the form of soft drinks. We have these big gulps and these other places that we're lacing our life with fructose. Fourth bullet here talks about fructose causing and depleting hepatic ATP and impairing recovery from that ATP depletion. Depletion results in a picture of mitochondrial toxicity. The key thing on this very complex graph is the super top line, which is palmitate. Palmitate's one of the oils that's in palm oil, for example, but in a low level in olive oil. So different types of oils that we can drink, including coconut oil, can have high levels of palmitate and become a lipotoxic and a stress to the endoplasmic reticulum and mitochondria. The biome is directly involved with leaky gut, tight junctions, endotoxin release. This metabolic endotoxemia is terrible, driven by different bad bacteria. On this one, they're highlighting bifidobacterium. But this endotoxemia, these bacterial translocations interfere with T cell activity, go to the liver, cause lipogenesis, drive inflammation, oxidative injury, insulin resistance, and also do that in the fat and the muscle. You can change this balance by placing your patients on a vegetarian diet. It really does reshift the biome towards an antioxidative, reductive type state. It improves tight junctions, decreasing this endotoxemia that's taking place. This is altering the biome. This is an animal model of NASH with carbon tetrachloride. Same thing happens in humans. The biome changes drive cirrhosis. As people develop cirrhosis, the biome worsens in terms of its profile. Most important thing on this table is the lower right-hand corner, genetic modifiers of fibrogenesis. I predict within 1 to 2 years, you'll be ordering panels through Quest and getting results back like PNP, LA3, TM6SF, MBO, HSD, and telling you about that individual's risk of progressive liver disease to cirrhosis. And this relates not just to fatty liver and metabolic associated fatty liver disease, but also alcohol-induced injury and things like hepatitis C, although hepatitis C now is a small problem because we treat and cure. Many of these patients are symptomatic with fatigue, malaise, and cognitive dysfunction. You're going to see hepatomegaly in a substantial number of patients before they develop cirrhosis, but splenomegaly is usually late F3 or true F4. Splenomegaly can be assessed by doing a spleen size on every ultrasound and getting a portal vein diameter on every ultrasound. Highly recommended. I think it should be standard. AST can be higher than ALT in fatty liver, but that usually indicates F4. The AST is close to the ALT level. It's probably F3. Every patient needs to have a full lipid panel, fasting blood sugar, hemoglobin A1C, making sure hepatitis A, B, and C are negative. Patients are vaccinated for A and B if appropriate. Iron studies of persistently over 50%. You're going to be getting an MR with iron quantification. And of course, you can pick up fatty liver on ultrasound or CT. So you're going to do imaging. You're going to take a meticulous alcohol history. You're going to order PEth testing on any patients you even have a whiff of a hint of alcohol abuse or use. Autoantibodies, I only do if globulins are elevated. I don't ever check ferritin. I'm going to go directly to iron saturation. Fasting lipid profile is important. Measuring insulin resistance may be important, or you can assess that indirectly. Liver biopsy, almost never done in clinical practice. Ultrasound, qualitatively good for picking up fat. You have to have really over 15 to 20% fat for the ultrasound to give you a good read. But elastography, very useful. FibroScan is just one form of elastography. There's 2D point shear wave, 3D shear wave, RFE, MRE. There's computed tomography, which is not so good, but MR is great for calculating fat fraction with the PDFF. You can also do MR elastography. Back to elastography, VCTE, that's FibroScan, but you can measure fat using what's called controlled attenuation parameter. So non-specific symptoms, very important. Non-invasive biomarkers are going to come to the forefront this year when Quest rolls out ELF and LabCorp rolls out NIS4. When those get on the market later in the year, we'll have a short presentation on how to use those. The liver biopsy is the gold standard, but remember the gold standard went out of banking in this country in 1933. So biopsy to me is really a second and third line test. What else can you do? You're going to look at AST and ALT in every patient. You're going to get a BMI in every patient. You're going to get a fasting glucose. You're going to get a hemoglobin A1C. And I strongly recommend getting a C-reactive protein. Adiponectin and CK18 are not commercially available. Of course, you're going to look at HDL, LDL, cholesterol, and triglycerides in all your patients. This is prevalence of NASH, just talking about that among US middle-aged cohorts. So you're up in the 12%, 14% range here, but fibrosis stage 2 to 4, which is substantial, it's in the 6% range. That's a huge deal for a country with probably 270 million adults. This is by subgroup in a middle-aged cohort, where a lot of us are, like John and I. So BMI over 30, 60% of MAFLD, 24% have NASH. Once you have diabetes, BMI over 30, and hypertension, you're jumping up into 50% of patients. These are stress adipocytes. These are what leads to hepatotoxicity, increasing fat supply, increasing triglyceride formation, increasing lipotoxic fat in the liver, but also in muscle. There's a lot of fat that goes into muscle tissue and can cause muscle toxicity as well. You have this ER stress, you have mitochondrial dysfunction, Cooper cells become involved, and then hepatic stellate cells morph into myofibroblasts. A lot of drugs down at the bottom that are listed off, some of which are still in development. Type 2 diabetes is a risk for advanced fibrosis by FibroTest, which is a blood test, MAFLD score, which is an online calculator, and VCTE. So we can take a look at that in the type 2 diabetes. Advanced fibrosis is found in over 1 in 5 diabetic patients, a serious risk factor. Type 2 diabetes, a little bit more information on risk for NAFLD or MAFLD here. You've got liver fat greater than 6%, markedly driving up that BMI or associated with a higher BMI. Requirement for insulin. Now, here's a really good important issue. I try to get all of my fatty liver patients off insulin. I want them on metformin and a GLP-1. I'm going to assess hypertension, but as the liver fat goes up, hypertension percent goes up markedly, as does liver enzymes, ALT. So let's see. I think we've talked about everything on here except gout. So inflammation in the liver, insulin resistance drives hyperuricemia and drive gout, another complication of this metabolic syndrome. We've got fats, we have inflammation, we have fibrosis, we have genetic predisposition, we have diet predisposition. So there's a lot going on, and we're going to stage every patient. Ultrasound showing fatty changes, which is a bright liver echo texture increase compared to the kidney. Some vascular blurring helps support this diagnosis. All right, a little bit more about this continuum. Steatosis without inflammation, without fibrosis, steatohepatitis, and NASH. Ultrasound can tell you if there's fatty liver, but can't tell you how much fibrosis there is unless the portal vein is dilated and the spleen is enlarged at greater than 12 centimeters. Portal vein should be less than 12 millimeters. CT can show this bright characteristics. What can we do? Weight loss is key. I'll show you data. And every patient should be losing weight by eating less, having a nutritional consultant, changing their diet. This is very possible. I do give all my patients F2 and above vitamin E at 800 international units per day. The data I'll show you shortly. I rarely use direct insulin sensitizing agents. I'm more likely to use metformin, GLP-1, SGLT2, DPP, and that sequence. No patients on Piolitizone, and all the patients are off insulin as soon as we can. Check a C-peptide. C-peptide's high. They don't need insulin. They're already insulin dominated. Lipid-lowering agents will not reverse NASH, but can decrease risk for liver cancer, decrease risk for cardiovascular disease. I see them indirectly as being hepatoprotective. This is about the data on weight loss or diet and exercise. And then the bottom 4 is surgery. So we've got lots of ways to get weight, and this can improve ALT. And when they do biopsies, we have biopsy information too. Weight loss works. A little bit more data, 31 patients, randomized controlled trial. Intervention group, 40% lost more than 10% of body weight versus 0% in the non-intervention group. This is lap banding, mean weight loss 34 kilos, histologic improvement across all these patients with only 4 fulfilling criteria for NASH. All the other ones, all these different parameters are resolved or improved or disappeared. 10% body weight range, you can get fibrosis regression in 45% of patients. It's very likely you'll have a graph like this or a statistic like this on your boards. This is what happened after bariatric surgery. First on the left, before surgery, 8.5 months after surgery, got agreed to another liver biopsy. You can see almost all the fat and fibrosis is gone. This tells you how reversible this disease is. Bariatric surgery reduces the risk of liver cancer and other somatic cancers by getting rid of the fatty liver. And of course, on top of that, behavioral modification of the patient. In this Swedish study, they said if you're really aggressive about structured weight loss program, you don't need to do surgery. But that's the Swedish population, very obedient, and could easily follow this. This is unlikely to happen in the US. Structured obesity management, though, might cost $2,000 a patient, and bariatric surgery is $20,000 a patient. I don't understand why the insurance companies don't take a stronger lead in this, but maybe they're overwhelmed by the numbers. You have millions of patients at risk or having significant liver disease. This just shows you on this regression analysis. Blue is conservative management, surgery in red. So when you're aggressive about your conservative management, things can get a lot better. Lifestyle modifications, weekly meetings for a while and then monthly. Moderate to low carb, low fat, low glycemic index, fruits and vegetables, moderate intensity of workout daily or an hour every other day, Monday, Wednesday, Friday. They did document resolution of metabolic associated fatty liver disease in 64% of the intervention group, 20% of control. So instead of paying for all these medicines, all these insurance companies should be paying for us to go to the gym with a personal trainer. Degree of weight loss and resolution of metabolic associated fatty liver disease by measuring triglyceride content. I think this is MRS, the way they did this one study. But as you lose weight, let's go to the 10% column on the right. Suddenly you're at a 97% of resolution of fatty liver. Weight loss works. Love to have a better weight loss drug, right? Ketogenic diets work. They definitely reverse MAFLD. But ketogenic diets need to be on short term because long term they can cause and wreak havoc with your kidneys and other organs. Exercise works. Large cross-sectional study, although self-reported, nearly 1,000 patients. They had exercise categories: inactive, moderate, vigorous. Vigorous exercise was associated with a decreased adjusted odds of having NASH. Doubling recommended time spent with vigorous exercise to more than 150 minutes a week was adjusted with decreased adjusted odd ratio of advanced fibrosis. So you want to burn 400 calories per session, at least 3 sessions a week, at least an hour each. Those are really good numbers to be thinking about. Sleep, better sleep quality, longer sleep in terms of numbers equals quality, causes more weight loss. Lipid lowering agents, just showing these do improve ALT, but rarely do they do biopsies. And if they did, they didn't show direct association. I hate Piolitizone because of bladder effects, heart failure, fluid retention. I just don't think it's a good drug, but vitamin E is safe, and I think it's very useful. This is Piolitizone and vitamin E in the Prevalence trial. As you can see, Piolitizone did the best with fatty liver improvement, what's called NAS score improvement. Second one is probably Piolitizone had better effects on inflammation and steatosis, but vitamin E won out on ballooning improvement. Piolitizone, weight gain, cardiac toxicity, fracture risk, bladder cancer, all reasons I don't use it. And of course, on the right side, you're seeing the benefits of just standard treatment in terms of histology, insulin sensitivity, and liver enzymes. Piolitizone, vitamin E, and Piolitizone. Piolitizone did work, but I think the benefit risk ratio is close to 0. I would score it as 1 with something like Piolitizone winning or losing. There's not a -1 on this. Piolitizone was associated with improvement in these patient outcomes. Okay, I'll go back one. Vitamin E, simple to use, rare side effects, long-term safety looks great. This prostate cancer question about vitamin E has to do with if you're on vitamin E and you have prostate cancer, it can be more aggressive. There's no data to show that it causes prostate cancer. FXR receptor or beta-cholic acid is sitting in front of the FDA. This binds to these nuclear receptors and enhances lipid metabolism, rebalances carbohydrate metabolism, decreases inflammation and fibrosis when you block this activity. In phase 3 is a number of medications. This is a little bit out of date because the Aramcol, I don't think is moving forward, but resmetirom and obeticholic acid hopefully will be approved this year sometime. Elafibranor looks good, but there's a better drug that came out behind that called lanifibranor. Looks also good, PPAR alpha gamma. Belapectin is gone. Cenicriviroc is gone. I think belapectin might be going back into a trial somewhere. Just one second. Got a Alexa going on in the background somewhere. Okay. All right, so cirrhosis too, you have to look at as more than a single stage. We go F0 to F4, suddenly F4, you're cirrhosis, and then you stop. No, you have to subcategorize those patients: varices, ascites, cephalopathy, liver synthetic tests, portal hypertension. All those things go into what's happening. What's the MELD score? What's the CPT score? Then subdivide F4. Once you have cirrhosis, it can be reversed. Early cirrhosis can go back to F1, not necessarily normal, but there are ways to reverse the cirrhosis, provided that we catch it early. A lot of drugs in trials, and hopefully more things to come. It's very exciting, but billions of dollars have been spent. Nothing has been approved. But there is a lot of science behind this, targeting inflammation, targeting the stellate cells, myofibroblasts, collagen degradation, and you can go into pro-factors and block lipoxins using resolvins or protectins or maricins. GLP-1 are the favorite though, and these are FDA approved for both diabetes and weight loss. And patients lose on average 4 to 7 kilos when they're on the GLP-1. We do add GLP-1 to metformin, so metformin should be your base, and then you add GLP-1 next, make sure they're off insulin or off Piolitizone. Then you can add in a SGLT2, and then finally a DPP. Consider that as part of your formula. Liraglutide is being replaced by semaglutide, especially as we're getting to once a week injection. But these drugs do cause weight loss because they provide a little bit of an emotional high for the patient, which is important. They also decrease gastric emptying, and they have a number of other very favorable effects. So semaglutide, metformin are the two wheels on the car at a minimum. These new drugs are targeting all these different targets in terms of modeling. They're throwing a huge amount of money at this. It is a giant market, but no one's gotten very close to the goal line. The obeticholic acid finished a very large phase 3 study, met the endpoints, but had some evidence of liver toxicity that I think is over-exaggerated. But the FDA is very worried that these drugs get into the hands of a community person, community provider, and then they start developing liver failure because the community provider doesn't know how to realize or measure liver function. They look at the enzymes, they're not too high, put them on the drug. Whereas they may have giant varices, may bleed because the variceal ruptures. There's a variety of bad things that can happen. Okay, so we want glycemic control. Metformin, GLP-1 is your foundation. Off insulin, off Piolitizone. Atherogenic lipid improvement, you can do that with your statins or maybe add fenofibrate. You can refer them to a nutritionist to be aggressive about weight loss and follow-up. And you get this reduction in lipotoxic fat, NASH resolution, fibrosis improvement. A little bit more on treatment pathways that can include FGF19, FGF21, FXR, GLP, thyroid beta agonists, FASN, and ACC inhibitors. And then we can go directly to anti-inflammatory drugs. This just lists off a variety of different drugs that are in process here. I'm not going to go into great detail, but we can attack this at multiple places. Okay, we're getting close to the end. We're at the end of the beginning anyway. Understanding NASH, we really need to get some drugs approved. We have vitamin E. One of my friends, wanders around and, thinks about other things such as green tea, which is safe, coffee, safe, but it's really back to losing weight. It's absolutely critical. The biome, I put all my patients on probiotics. I put them on a vegetarian diet, calorie restricted diet, 6 snacks per day, especially if they're cirrhotic, which helps rebalance catabolism. Don't biopsy. That's rarely done unless you've got a really good reason. This is a clinical care pathway that Canwall published. This is going to take place by endocrine, gastro, primary care, obesity specialists. You're going to basically, look at how many diabetes levels they have, other complications of metabolic syndrome, You can do liver enzymes, liver function, check for alcohol intake. Don't ask them a question, just order a PEth. I'll give you a lot of information. Non-invasive testing, NATS was easy, FIB4, APRI, MAFLD score, but you'll even do better now that we have a number of new non-invasive tests that are much more advanced. We categorize risk and decide where we're going to put those patients. Indeterminate or intermediate or high risk needs to be focused inside a hepatogastroenterologist. Take a good history on alcohol, order a PEth test, make sure hepatitis C and B panels are negative, hepatitis A is negative, autoimmune workup only if the globulins are elevated or the enzymes are in the 200 to 300 range. Really elevated, definitely got to do that autoimmune assessment. Came up with this low, intermediate, and high risk in a tabular format, including lifestyle intervention, weight loss, pharmacotherapy, cardiovascular risk reduction, diabetes care, eat more easy with our new algorithm. So some pearls, you're going to put all these patients on statins and target a very low LDL in the 40 to 70 range. Loratadine, good for allergies. Bupropion, good for sleep. Also, and we want to avoid SSRIs because they have a lot more weight gain to them. Effexor also has a weight decrease. Provedolol is misspelled on here, sorry, but I would use that after patients failing in bariatric surgery. Not my statement is don't use Piolitizone. So MAFLD is a systemic inflammatory syndrome that drives cardiovascular disease, stroke, heart attack, kidney dysfunction, orthopedic issues, and needs to be fully assessed in all of your patients. 10% weight loss goal for the first intermediate step. Exercise at least 3 hours per week with a heart rate over 100 per minute. Statins are great to control lipids. Bariatric surgery, $20,000. We avoid dietitian for all patients, weight loss contract. We have one that we use that I can send to you or is available on my website. I love these contractual ways to deal with patients. Let's see. Oh, that's the end. So now time for Q&A.